feel like I drew the short straw here with this one, but these these are fun cases, challenging cases, but they all come in after 10 p.m. at night. These are the photos that you get from your residents. So wrist injuries account for about 2.5% of all the ED visits, and about 5% are perilunate injuries. This happens in a younger population with good bone stock and are very, very high energy injuries. The interesting thing, if you look through the literature, a lot of these are missed, and you look at some of these x-rays and you wonder how they can be missed, but there are some subtle ones that are definitely missed. When you think about perilunate fracture dislocations versus perilunate dislocations pure, it's a 2-to-1 ratio. 97% are dorsal, 3% are palmar. The dorsal transscaphoid perilunate dislocations comprise 61% of all injuries. And a lot of you can really geek out on a lot of this stuff, but it makes sense when you look at the different arcs here, and you see the lesser arc injuries, which are purely ligamentous, going through the ligaments, creating an injury that I'll show you. And the greater arc injuries here, they go through a variety of different bones. You can have a variety of different injuries here, with the scaphoid being the most common, which we're focusing on today. Again, this could be, we can do a whole seminar on the palmar ligaments, but they're very crucial. They're very sturdy ligaments, and they're crucial for, to prevent translation, rotation, and angulation. But the take-home point here is to kind of draw the point about our lunate dislocation is they form these two inverted V's on the palmar side of the hand, and there's like a weak area, the space of Poirier, as they call it, where the lunate can pop out through during some of these injuries. Another important point here, too, in the ligament that I've kind of outlined here is the radioscapholunate ligament, which carries the blood supply. And I think some of these bad lunate dislocations that do badly are because of loss of blood supply due to the dislocation itself. Dorsal side is not as exciting. You see the ligaments there, but the scapholunate interosseous ligament's very robust and very complex. It's C-shaped. There's 3 components to it: the volar, dorsal, and membranous component. The dorsal is the one that we focus a lot of our attention on. It's very thick. It's 2 to 3 millimeters thick and provides the large amount of stability here, whereas the volar part is only 1 millimeter thick, and we don't spend as much time thinking about that. But the complex itself derives a lot of external support from the external ligaments that are all connecting to it, as you can see in the diagram there. So as I mentioned, this is a high-energy injury. We looked at our data, which I'll refer to a couple times in the presentation that we wrote up last year. You see our patient population of 33 patients that we treat at the General Hospital, largely from falls, motor vehicle accidents, bicyclists struck by automobile, assault, and a variety of things. But these patients suffer this injury: a fall on the outstretched hand, and wrist extension, alternate deviation, and supination at the mid-carpal joint, where you get the disturbance of the ligaments. I think we've all heard of the Mayfield classification. If you think about how this injury happens, as the injury goes from radial to ulnar, you have a variety of injuries as Mayfield is classified here. And the stage 1 is a straight scapholunate ligament injury where there's a scapholunate dislocation, as you can see here. Stage 2, the lunocapitate dislocation, which is also known as our perilunate dislocation, and this is where the scapholunate and lunocapitate ligament rupture. The lunate in this case remains aligned with the distal radius, and the surrounding carpal bones are displaced. Now we move on to stage 3 here, the mid-carpal dislocation. The lunotriquetral ligament is ruptured, and/or a partial avulsion of the triquetral bone occurs. And this is where the lunate and capitate lose alignment with the distal radius, as you can see in the cartoon from on the left there. Then finally, stage 4, we have complete lunate dislocation. The lunate is dislocated, the dorsal radial lunate ligament is ruptured, and this creates what we all know from our various exams and things on x-rays as the spilled teacup sign. And so basically the result of the circumferential disruption of the lunate, it creates rotation and dislocation through that space of Poirier, which I showed you guys earlier. So the presentation, and it's interesting when you look at these presentations, you read about 10% are open, typically palmar laceration, and I was looking through my cases and I actually found one of my patients with exactly that, where he had an open injury from a perilunate dislocation. These patients come in with very significant wrist swelling, so you have a high level of suspicion. The fingers are flexed, they have a lot of pain with passive range of motion, and it's variable, and a lot have median nerve paresthesias. This is what the literature shows us. I feel like we see higher nerve paresthesias in our population, and 26% are associated with polytrauma. And again, you can see in our data, the majority of our patients are male and with an average age of about 34 years old. So as I mentioned earlier, oftentimes the more subtle ligamentous injuries can be missed, and the literature says up to 25%. As I mentioned, we have to have a very high clinical suspicion. They have very impressive swelling, and x-rays are indicated. And interestingly enough, you'll see from some of our data, we get advanced imaging, but really all you need are x-rays to diagnose this injury. So what do we see in our x-rays? Some are very subtle, as I said. You see a disruption of carpal arcs, you have overlapping of carpal bones. This seems kind of crowded, foreshortened carpus. I'll show you in the next example of a triangular lunate and greater arc fractures. And you can see in our patient population that we ultimately did some patients just got, over half of our patients just got x-rays, but some of our patients got x-rays and CTs, and I'm not sure why, but 2 patients just purely had CT scans. So, again, when you're looking at this, some of the fundamentals, the glueless lines, as we've all learned about, if you follow that principle, again, as you follow your arcs, the 3 arcs that we have, you can see what we demonstrate here is the lunate looking kind of triangular when you're looking at the glueless lines. The lateral view, as I showed earlier, you see the lunate and or distal row are not aligned with the radius. If you measure the angles out, the scapholunate, radial lunate angles are abnormal, and you see what we have is the spilled teacup sign. So in essence, we've lost the collinearity between the capitate lunate and distal radius. So the physical exam, they usually come in with very severe swelling. One of our first evaluations are looking for acute carpal tunnel syndrome. Some actually almost present like a compartment syndrome of the forearm, and neuropraxia, and some of the more subtle findings may be the only thing that we see in some of these patients. And again, in one of my patients here, you can kind of appreciate the short and thick wrist. They have limited range of motion, crepitus. They may have a palmar or dorsal prominence, as you see in this patient, and then the median nerve symptoms secondary to that lunate dislocation. And we try to get these reduced as fast as possible in finger traps in the ER. Sometimes if they're sitting around the general hospital ER for some time, they swell up, and as they swell more and more, it becomes more difficult to reduce these. You want to check your 2-point discrimination pre and post reduction. The maneuver here, it works really well. Wrist extension, you place counter pressure, palmar over the lunate, and gradually flex the wrist with direct pressure over the capitate. One of the interesting things is if the lunate is completely out of the fossa, like some of our patients have, reduction is very unlikely. And given that radioscapholunate ligament that I showed you earlier in my slide, you can jeopardize that blood supply if you're trying to reduce ones that are way out of the fossa. So operative or non-operative, I don't think there's much debate here. I think operative is really the goal here. You want to anatomically reduce the carpal bones, repair the ligaments, release the median nerve. When is it an emergency? Again, it seems like these come in the middle of the night. They all seem to have median nerve symptoms, and they all seem to be emergent, and some that we can reduce quickly and get them splinted and get them hanging. We can maybe keep them till the morning, but oftentimes not. But also the ones that have come in with those enucleated lunate, as I showed you before. Closed reduction in percutaneous pinning, and I don't think I've ever just purely done this. They talk about it in the literature. I think these are all unstable. Even when you reduce them, they all want to pop out after you reduce them. If you look through the literature, some people talk about just doing it in a closed fashion with arthroscopy and basically just pinning essentially everything. But I think most of us at this point think, because the outcomes, as we're going to show you, are not great, we want to get in there and address all the ligament injuries and also reduce or decompress the median nerve, which is almost always indicated. If it's not indicated preoperatively, it's almost always indicated postoperatively as they swell more after surgery. SOAP reduction is preferred. You get a good direct view of the injury, ligamentous repair. You can decompress the median nerve. You know, if you look through the literature, there are several approaches: dorsal volar, combined dorsal and volar. I think each of the cases are different. I think you may have to. I think most of my cases we end up going both dorsal and volar. But I think I'm going to show you a case here that I was able just to go dorsal. Dorsal gives a good view of the proximal carpal row. It allows you to fix the fractures. This picture shows how you put your joysticks in the scaphoid and lunate. You can kind of manipulate those bones to get things just perfect as you repair the scapholunate interosseous ligament. Volarly, obviously, we can do our carpal tunnel release. We can repair that capsular rent that's always there, reduce the lunate, and then repair the lunotriquetral ligament as well. Stepwise in this case, after you get reduction, I think, usually begins with fracture fixation. Dorsally, you can fix your scaphoid, capitate, or as any of the other fractures on that greater arc injury, as I showed you before. Ligament repair is needed. Again, if the scapholunate ligament is repairable, you can repair it directly if possible. Use bone anchors. Oftentimes it's not repairable, and I won't go into the variety of different non-repairable scapholunate potentials, but dorsal capsulodesis or the Brunelli tenodesis. There's a number of things that you can do to try to fix that ligament. And I got to say, thinking back in my cases, I don't know that I've ever been able to repair it directly. It always seems like an M80 went off in there and you have to use something to repair it. This just gives us some examples, and this actually kind of shows like that M80 look as I'm talking about. All the cartoons look great, but in reality, you really got to take stock of everything. And this is just showing repairing the scapholunate ligament. In the volar approach, you see the lunate popped out there, and you see your ligamentous tear here. Hard to project. I got another picture of that coming up here in one of my cases. So here's a case, a patient that comes in. You see this is a young guy, a high energy injury. He happened to fall off like a 30-foot bridge, intoxicated, as is likely always the case. There's his lunate you see there. He got a good reduction in the emergency department, as you can see, but obviously unstable. Go to the OR, you can see the approaches here with the fixation of the scaphoid. Again, it's like, when you go, you fixate different things, and you got to get a lay of the land, and this shows the approach. And I think I was trying to demonstrate the space of Poirier there with the rent in the palmar capsule. Another case, and again, this patient shows that a lot of the signs, a shortened wrist. You can kind of see the abnormal look of the wrist dorsally. Here you see the X-rays with the lunate out. Again, this I think did the dorsal approach, was able to fix everything. This was not. We didn't have a scaphoid involved here, obviously, but we were able to get good reduction of the fracture. So these patients are immobilized for some time postoperatively, removing the K-wires at 8 weeks. I think initially on, I had K-wires in for 10 to 12 weeks, which did not have good outcomes. Do you see the cast and start range of motion at 10 to 12 weeks? You can maybe do it a little bit sooner in a more reliable patient. Some of the complications that we see, as I mentioned, arthrosis, but also the avascular necrosis, which is not a common complication. It's more often the transient ischemia, median neuropathy, residual carpal instability, and all these patients seem to have a significant amount of stiffness. So what are the outcomes? We do all this work, and no matter what you do, it's a pretty poor prognosis to return to previous function. Some of the indicators for patients, with open injuries, delayed treatment, and the data you see, you can treat these up to 2 or 3 weeks successfully, but after 45 days, it kind of falls off a cliff with your outcomes. Osteochondral fractures that had the capitate don't do well. Continued carpal malalignment, obviously. Nearly all patients experience decreased grip strength and range of motion. Arthritis on imaging is common, but it doesn't oftentimes correlate with their functional outcomes. They're usually very stiff, and oftentimes they have low pain, which obviously is a good thing in this circumstance. There's not a lot of data in the literature looking at outcomes, and even our patient, we had 33 patients, and the follow-up rate in our population is very, very low. So it's very tough to get a handle. But here you see 2 studies, 25 and 14 patients with okay outcomes. In the first study by Knoll, there was 89% return to work. The flexion extension is 113 degrees. And no arthritis in that study, which is somewhat unusual. In the Hertzberg paper, with only 14 patients, I don't know what you can take away from that, but a lot of midcarpal arthritis with a similar flexion extension range as in the other paper. So in summary, I think you have to have high clinical suspicion of this injury. Try to get these reduced as fast as possible. I think open reduction, internal fixation, ligament repair is the gold standard. I think ahead of time you really want to advise the patients about stiffness, weakness, and development of arthritis. And I think thinking ahead, at 70 to 80% of range of motion and grip strength is a good result in these patients. And I think acknowledge my partners in crime. We have a fairly big growing hand team, orthoplastic at UCSF. So thank you so much.